This is the journey of DCB, been a long time. This is all the studies. You don't need really studies whatever study you can see, you can critique. Like yesterday, today I think we're talking about the balloon and IVL. Now we have randomized clinical trial, tells you there's no difference. Oh, no, there is some problem with it. You never be convinced if you have that skeptical approach to any trial. So be careful. Any new things, always resistant. So today I'm going to mention one important thing, how to prepare the lesion. I'm going to ask the experts here. So Shekwat, Umar, Ali, Hussein Hishmet, how you prepare your lesion?
So I think the problem here is what I have experienced is we don't have long NC balloons on the market, not available in any cath lab. We know that some brand has, but I prefer always long NC balloons. And for that reason, because we don't have long NC balloons sometimes in the cath lab, I use a scoring balloon. It's a NC balloon, it's a wedge NC balloon. And after that preparation, and I was, if it's not a CTO, as Omar pointed out, I agree totally with him. If it's not a CTO, then I definitely go with IVUS. And after wedge NC, scoring balloon preparation, I would go with the DCB. But my default approach is always use a scoring balloon at least. If we have more calcification, then maybe sometimes I go with the cutting balloon and always use long NC balloons for preparing the lesion.
Hussein Hishmet, when are you happy to apply your DCB? You say lesion preparation is a relative thing. For you, what is optimized, Hussein Hishmet, optimized lesion preparation to apply DCB?
We need to have two conditions. Number one, TIMI3 flow. Any flow less than TIMI3, then no for DCBs, number one. Number two is a residual narrowing that is less than 50%. If I have both conditions, then DCB. If one or none, then stent.
So if the lesion is more than 30%, stenosis.
You mean after well preparation? I
don't know what well preparation is. So you done your preparation, it's still more than 30.
Well, preparation is a form of a hierarchy. The minimum thing that I would do is an NC balloon.
Okay.
If it works, well and good. If it doesn't work, then I would escalate either to a cutting scoring.
When do you think is enough?
If I don't see, if I still have a residual narrowing.
Yeah, when is that? After 2 minutes, 3 minutes? How long are you going to keep expanding?
Yes. As we engage into drug-coated balloons, now we learn that we need to inflate slower, and we maintain the balloon inflation for 1 or 2 minutes as long as the patient tolerates, and then we deflate also in a slower way. So if NC balloon doesn't work, cutting scoring, that's one direction. High pressure balloon, OPN, that's another direction. And if from upfront I see a lot of calcium, either by fluoro or by imaging, then rotablation.
Right. Anyone else? Johan, Omar, anything you want to say?
So
preparation lesion.
Practically, I tell you what I say. For CTO, I'm using IVUS a lot. Maybe 80% of the CTO we use IVUS. And if we use DCB, of course, I'm using IVUS data. But in routine practice, if I have, for example, LAD lesions, I size the vessel by angiogram, not IVUS, if I like to use DCB. And if DCB, so if I see any calcifications, if I believe that the lesion has to need better than NC, then I directly do cutting balloon or scoring balloon. And after that DCB, and if I like the result, I do NC and then DCB. If I have a recoil after NC, I definitely do cutting balloon. In those patients, I see the result. If I have still recoiling, then I do stent. So that's my routine practice. I don't use routinely IVUS for DCB, if I do DCB.
Okay. Ali Masood.
Let me just say something. I think we need to have still DS and bioadapter and drug-coated balloon. My suggestion to have the DCB as the primary or default option, but there are tips and tricks that make DCB more successful. More liberal use of cutting balloons is very important. We need to be less sensitive to dissections. and aggressive medical therapy. I think these are essential tools to make DCB successful.
I agree. Yeah, we have to use more often cutting balloon or scoring. I agree.
Just for the cutting balloons, we use a lot of scoring balloons, and in the last years, I do the same as you do. We use cutting balloons because many people fear cutting balloons and say, well, you create dissections. First, dissections are good for DCB treatment. Why? Because the drug uptake is better. So you need dissection. So you need preparation of the vessel. And when doing scoring or cutting, you have controlled dissections, not as high pressure NC balloons, because then you disrupt the plaque. You have more controlled dissections. And what I call, and I think many colleagues do the same, when you have an ugly dissection, don't give up. Take your your cutting balloon, and you can rotate your cutting balloon to make different, it's not cut, it's like a scoring balloon, and then you can transform an ugly dissection in a beautiful dissection. And you had the algorithm here. It was TIMI-Flow 3 is the most important. Recoil, this 30% is for proximal vessels. For distal vessels, I think when you have disrupted the plaque, it can be 50%. I think then it's not as important, but I wouldn't do that for a proximal left main, and I think that is very important. And don't use the DCB for dilatation. DCB is just when you prepare the vessel, then you can, and this is with low pressure, apply the drug. And I do the same as has been said, go down slowly. I don't know if this is science, but I think you don't have the collapse of the vessel when you go back slowly.
And
We have the same.
Yeah, I agree totally with the 50%. So if there is a 50% rest lesion, then unless I don't have any TIMI-2 flow, TIMI-1 flow, if I have TIMI-3 flow, even if I have a barber dissection, and if I have a very good flow at the distal, TIMI-3 flow, very brisk flow, even if I have a D dissection, I leave it.
Okay, so you're speaking about stable plaque, you causing the dissection to use your DCB. What about STEMIs? What are you going to do? Silent.
So the concern with STEMI is that there's a big thrombus lining the endothelium, and there is a chance that the drug will not penetrate into the intima media to induce its anti-restenotic effect. So first you need to clear the thrombus completely, whether you do that by thrombus aspiration, 2B3A blocker, a balloon. You need to clear the thrombus completely, and then you go for the DCB.
Yeah. Anyone else experience DCB and STEMIs?
There are some data on STEMI and non-STEMI with DCBs, and I think this could be a field of future, showing that there is no difference. DCB is not inferior to stents in the outcome for non-STEMI and STEMI. I think STEMI is not STEMI, so you have sometimes a lot of thrombus load where you don't want to do something. The only thing you want to do is restore TIMI-Flow 3, give anticoagulants, and come back. And sometimes you have surprises, and then you see plaque is not as big. And then I think you could apply a drug-coated balloon, and you don't need a stent. So this is a field that is evolving, but I think we should open the door to also explore these options, because in STEMI you have also distal vasoconstriction. So the stent normally is too small when you put it in the acute phase.
Okay, any question from audience? Yes, Muzakbar.
Thank you very much for the nice discussion and presentation. Just for you, from your experience, what is, if any, role of using DCB in coronary ectasia where you have a big geographical mismatch? Would you use, if the size of the drug-coated balloon is not enough to inflate after preparation, do you use kissing balloon too to accommodate the size? If the size of coronary ectasia is 5.5, would you use drug-coated balloon 2.5 with the 3 together and you inflate it to avoid putting a stent because of the geographical mismatch?
Well, that's not recommended, because when you inflate two simultaneous balloons in that kissing manner in one lumen, then they will not conform to the vessel wall, and the drug will not be delivered circumferentially through the 360 degrees. We know that from the bifurcation work, so probably not.
Muhammad Subhi.
I have a comment and question. Quentin, Antonio Colombo doing the long lesion of diffuse disease is to prepare the lesion and there is non-occlusive dissection. There is no IMAX distally. You leave it with the DCP and with spot stenting. This is what you're doing for the lung diffuse disease. My question in the recent guidelines, chronic coronary syndrome, showing that DS is better than DCP in in-stent restenosis. How do you explain this difference now?
So the new
In
guidelines.
the recent guidelines,
So, yeah,
European
the-
guidelines.
Disappointing, this guideline. but-
Disappointing.
Yeah, this is my topic. Until 2019, we had a class 1A indication for in-stent restenosis with DEB, okay? But then in 2020, the guideline was in 2019, and then we had 3 randomized trials, so 2 meta-analyses and 1 randomized trial. And according to that trials, the Desire 3 trial, there was no difference between MACE and even TVR or TLR. So we can skip this study. Then we have 1 meta-analysis and 1 study indicating that a moderately better TVR, TLR outcome in DES in the long term. So how will this translate into daily practice? It's up to you. For me, it doesn't change anything because I don't want to put a stent in an in-stent restenosis because this has a risk after 3 years becoming a TVR patient again. So I can deal with that problem again with some kind of different options, you know. And according to these 3 trials, the guideline suggested and referred, it is like this. So it's up to you how you, how you read it.
So always guidelines remain 2 or 3 years behind. Dr. Hussein Hishmet.
5 years behind because they are waiting
5 years.
for big trials and then they say something.
Yes. Hussein Hishmet.
The problem with in-stent restenosis, it's not a single disease.
Yes.
In-stent restenosis due to underexpansion or malapposition is entirely different from in-stent restenosis due to stent fracture or neoatherosclerosis. If it's a stent fracture, then DCBs will not do anything.
Yeah.
It needs to be stented. If it is a neoatherosclerosis, again, DS will have an advantage over DCB. Whereas it's underexpansion or malapposition, this can be easily corrected with a non-compliant balloon or with an IVL, and then DCB would be the ideal option in these cases. It's hard to randomize patients with different mechanisms of in-stent restenosis, but I think that's the way to handle in-stent restenosis.
So, and one of the Daedalus study with 10 randomized trial incorporated in the 2020 meta-analysis, 6 of them were BMS randomized trials. So they only left 4 and they gave the result with actually 4 randomized trials. And we should, I think, talk not BMS anymore, we should talk DES. So we need data from DES in-stent restenosis more.
So the key for my topic I've discussed with the experts here. So getting good dissection, controlled dissection, and for me, really being through this journey for a long time, I found STEMI the most beautiful dissection, which I can control it better with what they said, aspiration with the balloon. Then I get a best results with the STEMI until now. So let me finish by saying what they say. Tell me, I forget. صح? Show me, I remember. Then involve me, I understand. So, Waleed, do you want to say something?
Yeah.
Good.
Thank you very much all. It was really very nice discussion. We know that the mechanism of restenosis is recoil, new intimal proliferation, and
Yes.
negative
Yes.
remodeling.
Yes.
So just concerning about the operator who do CTO, I still do CTO.
Yes.
And leaving that without stent. Okay, we improve the flow, that will counteract the negative remodeling. Hopefully there is no stent, and that would counteract the new intimal proliferation. But now there is acute recoil, and if there is acute recoil, that's raise the incidence of restenosis. So for me, at least we need to wait 15 to 20 minutes to document that there is no recoil, together with IVOS to say that we'll accept this result and we'll wait for a few months to repeat that.
Time is, time is life. You can't wait 20 minutes.
No, but you can't leave that because
Yeah, but that's, I know, the same concept Dr. Walid used to say about DCB in the past, but now things are more, and you want to say something, Omar? Omar, you want to say? Okay, Walid.
Yeah, I think DCB is very different, to be honest with you. DCB, sometimes we have cases, we do routine 6 months follow-up for our case, and we have like 600, 700 DCB only cases in our hospital, just in our hospital. So we have lots of different examples. For example, sometimes we left because of the after CTO, especially we are more generous because it's CTO already. I have a nice collateral, so I'm trying to be more aggressive in that cases, because if something happened, occluded artery, nothing happened because I have a collateral. And in those patients, even I left some lesions, dissection, as my colleague Shehab told, I have 50% recoil sometimes, but that with dissection. I leave them, and I see after 6 months very nice flow and nice vessel. I was surprised how vessel tried to heal by time. It was very surprising for me.
Yeah, time to heal. Yes, Doctor.
Just one thing, I think DCBs are for giving stents, not, I think when you put in stents, it's fixed. And then we know treating in-stent restenosis is difficult. DCBs, you have no metal in. You have every options you want when the patient makes a restenosis. And I think 0% restenosis is not possible because it's a disease. So we have to accept that.
Salamat. Okay, to that end, I think we need to thank everyone, every speakers, the panelists, and thank you for interactive. Thank you very much. See you tomorrow, inshallah.